So we're very fortunate to have with us tonight Dr. George Risi. Dr. Risi is an infectious disease specialist at St. Pat's Hospital. He's also a clinical consultant to Rocky Mountain Labs. What he tells me is how he got into this whole issue about Ebola. So many of you know this, maybe some of you don't, that George was one of the first people called upon by WHO to go to Sierra Leone. The outbreak of the, well, not exactly the outbreak, but after the outbreak of Ebola this past year. He was there in August and September, pretty early on. Following that, he was able to go to Cuba, Antigua, and Panama, and train other doctors who followed him and went to West Africa to offer assistance. He most recently came back from training that he did with the CDC in Atlanta. That was last week, and that's why we postponed his talk to this week. So with that introduction, please join me in welcoming George Risi.
Okay, is this picking up? All right. To figure out how this works. Well, thanks and welcome, everyone. You sort of heard who I am, and I wanted to talk to you all about this disease for a couple different reasons. Probably one of the big things that I learned in being involved with this is, first of all, that a lot of us get our information about these kinds of diseases from all kinds of interesting non-medical sources, and that the news media, they certainly have their own agenda when something as juicy as Ebola comes along, such that by the fall of this year, this was kind of the posture that most people had taken, that despite all the other things that were going on in the world, that we were all very worried that we were going to catch Ebola and it was going to be a global pandemic. Of course, that all went away pretty quickly once the patient in Dallas was diagnosed, and then the doctor in New York. Despite the fact that Ebola deaths continue to rise, and now we're well over 9,000, the number of Google hits on Ebola, which reflects the general interest, I guess it's because the Kardashians have become more interesting, and who else has gotten pregnant or got arrested or whatever, such that really Ebola has sort of fallen off the United States radar screen, despite the fact that it's actually continuing to rage in Western Africa with some glimmers of hope, but an awful lot of reasons to be concerned that we'll talk about more in a little while. So what I wanted to talk about with you all then is what is Ebola? Where did it come from? How does it cause disease? What is the clinical spectrum of disease? I have a few pictures that might be a little disturbing, so I'll warn you, but nothing truly horrible, I guess. How do you diagnose the disease, treatment, talk about the current outbreak and how it happened and why it's going on, and then finish up with some personal observations. And I'd also like to acknowledge Kate Hurley, who's here, who had my back throughout the entire time that I was there, and without whom I probably would not have stayed safe and got home safe and sound. So, Kate, shout out. So to understand this disease, then, we have to go back to 1967 when there was an outbreak of a similar disease. This was an influenza-like illness among workers at a vaccine production facility in Germany, in a town called Marburg, and then additional workers in Frankfurt. And all these illnesses were amongst people who had worked with African green monkeys. And these monkeys were imported from Uganda and were either sick when they arrived or got sick shortly after. And these workers were harvesting the kidneys of these monkeys in order to produce a polio vaccine. Over the course of the investigation of what was going on, then a novel filamentous, if you will, virus, and I'll show you more about what that means in a moment, was described. And as is the tradition for a novel disease, it was given the name after some geographic location. And since it was in Marburg, Germany, it was given the name Marburg Virus. And the important thing, and the reason I bring this up now, is that Marburg and Ebola are very, very similar in the clinical manifestations as well as in the lethality of the illness. And so the people with that outbreak were managed with what was considered state-of-the-art treatment, which was back in 1967 was intravenous fluids and replacement of electrolytes, et cetera. And their mortality rate was 23%. So that's kind of been the goal for Ebola outbreaks as well, is to get the mortality rate down into that low range for that disease as well. Then fast forward to 1976 to a village called Yambuku, which is a small village on the banks of the Ebola River in what was called Zaire, which is now the Democratic Republic of Congo. And there was an outbreak again of a mysterious illness, 318 cases, and 88% of those people died. Simultaneously, there was an outbreak taking place in Sudan that caused an awful lot of deaths as well. And the investigation that was led by Carl Johnson revealed, again, a novel virus that was different enough from Marburg, but looked quite a bit like it as well. And so it was given the name Ebola after the river there, and that name has stuck with us ever since. Now, since 1976, there have been about 25 or so outbreaks of disease, and notice that the outbreak going on still now in Western Africa is far and away larger than any of the outbreaks, and actually larger than all the other ones combined. But the other thing to notice is that the frequency of outbreaks is becoming more and more often, such that now every year at least there's an outbreak of Ebola. And even in the middle of this outbreak that we were dealing with in Western Africa, there was a second outbreak that was taking place in Congo, and that was an unrelated outbreak, but was also caused by Ebola virus. So why are there more outbreaks? Probably because, first of all, there's more increased awareness. We've gotten better at our diagnostic abilities, but also, and very importantly, habitat destruction. We now, I'll mention in just a moment, the reservoir animals. And the reservoirs, their habitats are being destroyed, pushing them out of their usual places and forcing them to be more in contact with people or with the immediate animals. What is that host? Oh, I forgot my sequence here. So this is what the virus looks like, and it's called a Fila Virus, which is Latin for thread. It's if you just picked up a piece of thread and dropped it on the table, it would conform like this. And so this virus is unlike any other kind of virus. Usually, like influenza virus or the SARS virus or even the HIV or hepatitis B or C, they always have a very, very identical shape. You can identify them just by looking at them under the electron microscope. They always have the same shape, and that's very different from the filoviruses for a variety of reasons that we still don't really understand. They can take all these different shapes, all of which have to do with this long thread-like conformation. So Ebola is one of a family of hemorrhagic fever viruses, and as of 2015, there are about 19 different viruses that all cause a very similar kind of illness. They're all enveloped, and that's important because an envelope virus is easier to kill. It doesn't survive outside of the host for very long. And they're negative-stranded RNA viruses, and that also means that they tend to mutate more quickly than other kinds of viruses. And so you can see the Fila viruses, there's now 5 recognized species of Ebola that are listed in descending order of lethality, with Zaire Ebola being the most lethal, followed by Sudan, Bundibujo, Thai Forest, and Reston. And what's also really important to know is that of all these viruses, several of them have only been discovered in the past 5 years, to include the Bundibujo strain of Ebola and many others as well. And so it also is expected that there will be additional kinds of hemorrhagic fever viruses described, again, as the result of our increased diagnostic capacity, as well as additional habitat destructions happening. For all of these agents, humans are accidental hosts. So these are what are called zoonotic agents. So they're viruses that live in a variety of different animal species. In those animals, they either cause no illness at all or very mild illness. And human disease happens as the result of accidental contact with the blood or tissues from an infected animal, and that's what happens with Ebola, for instance, or inhalation of aerosolized secretions, or the bite of an infected arthropod, either a tick or a mosquito, as would be the case with yellow fever, for instance. And in all these situations, humans are dead-end hosts. The human is not part of the natural life cycle of the virus. So what is the natural life cycle of the virus? The usual, and we now think that at least 3 different species of giant fruit bats, and you can see how large this bat is, are the natural reservoir for this virus. And in those animals, the virus does not cause clinical illness. As the result, again, as I mentioned, of the bats coming in contact either with intermediate animals such as you see there, the great apes, or an animal called a duiker, which is kind of a deer-like animal in Africa. Those animals are very susceptible to the illness, and they get sick. If they're found in the forest, these animals are butchered for bushmeat. And in the process of butchering those animals, then individual human beings get infected. The other possibility is that the bats come in direct contact with human beings and cause illness. And then there's a lot of transmission within the family or within a small village as the result of rendering care to the loved one in your family. So I mentioned the great apes, and it's important to remember that Ebola does not affect just human beings, but all primates are susceptible. And there's been a huge impact on the great apes, such that in certain parts of the African continent, the great apes are actually at risk of extinction as the result of Ebola. These animals tend to be very social animals, again, and when one member of the group gets ill, then the other animals will take care of it, and in the process get infected in the same way as people get infected by taking care of their loved ones. So what is the spectrum of illness? Is it that everybody who gets infected is going to be sick and die, or is it more like the tip of the iceberg, where there's an awful lot more people getting exposed and not getting sick, as opposed to those who are actually clinically manifest? And that's a big question right now, and we still don't have solid answers for that. But there is intriguing evidence that there may be a significant number of people who are asymptomatic or who get ill but don't die and go on to make a complete recovery. And the precedent for that is even a disease like yellow fever, only about 1 in every 7 people who gets bitten by a mosquito and gets infected actually gets ill and dies. And the same thing for Lassa, Crimean Congo hemorrhagic fever, Rift Valley fever. The majority of people who get infected by these agents actually don't get sick at all, or only get mildly ill. So that's a big question mark, is what's the situation for Ebola? And there is some intriguing evidence that came out several years ago from Gabon, which is one of the countries just south of where this outbreak is happening now. These investigators looked at over 4,000 adults, 360 children from the rural parts of Gabon, And over a 3-year period from 2005 to 8, they sampled people from 220 different villages that represented all different kinds of villages in terms of savanna versus forest versus lakeland areas, etc. And these individuals donated blood, and their blood was tested for antibodies to the Ebola virus. And what they found, first of all, was that about 15% or so of all adults were seropositive to Ebola. And you can see on the bottom line there, the incidence was much higher if you were a resident in the forested areas as opposed to the savannas, as opposed to the lakeland areas. And as many as 20% or so of people in the forested areas, which is where bats tend to congregate, were found to be positive. Now, we don't know what this means in terms of are these people actually immune to the virus or not, but we're pretty sure that they actually were not a cross-reaction, because all these positives were then subject to additional testing by what's called a Western blot test, and it's much more specific. These people also had activation of their immune system in a way that would suggest that they actually did have some kind of an immune response. So the authors of this article speculated that perhaps while gathering or consuming fruits that were contaminated by bat saliva or bat droppings, individuals are exposed either to low levels of the virus, or perhaps because the virus, again, is very labile once it leaves the host, and sunlight will break it down. So perhaps they were exposed just to dead virus, inactivated virus, but still had some kind of an immune response. So this is very intriguing, and again, I think we're going to learn an awful lot more about that specific question once the dust settles and we finally have a chance to pick our heads up out of the water with this current outbreak. So how does Ebola cause disease? I don't want to overwhelm you with immunology, so I just want to show a few slides, though, talking about the fact that Ebola affects both the innate and the adaptive immune responses as manifest by the macrophage and the dendritic cell. These are two very, very important cells that are involved in fighting off different kinds of infectious diseases to which we're all exposed on a regular basis. Both of these cell types ingest Ebola, but instead of digesting it, killing it, the virus actually survives inside those cells and goes on to cause disease. So the macrophage its job in life is to sense pathogens, ingest them, generate nitric oxide and other kinds of reactive oxygen species, recruit more macrophages to help sort of take care of the infection, and to elaborate a variety of cytokines, which are chemicals that cause you to feel sick. So tumor necrosis factor, interleukin-1 and interleukin-12. These are the kinds of chemicals that are elaborated by your body that make you feel sick. They give you the fever, the body aches, etc. And they also elaborate a chemical called tissue factor, which is responsible for starting the bleeding cascade as well. I show this just because this is such a beautiful picture of what a dendritic cell is supposed to do. It senses, again, it's migrating and detecting this bacteria here. It sends out this big pseudopod, ingests it, and again, its job is to kill the organism, digest it, and then present pieces of the organism to T cells to initiate the adaptive immune response, which is the response meaning your ability to generate antibodies, and the T cells, which you've heard about with HIV, for instance, those are all part of the adaptive immune response. So what happens if these cells are not able to kill the bacteria, the virus? Instead, what happens is they behave like Trojan horses, and so they carry live virus away from the site where the virus first entered the body and go to the liver and the spleen and the adrenal glands and cause disease there. They also cause the blood vessels to relax, so-called vasodilation, and that's one of the big problems we see is the blood pressure drops as the result of those blood vessels being invaded, being relaxed. So that's kind of in a nutshell what happens is that these viruses are able to really significantly impact your ability to fight off disease. So when you first come down with Ebola, the manifestations are quite non-specific and look very much like a lot of other diseases that we see in Africa, to include malaria, to include typhoid fever, to include dysentery, etc. We used to think that the onset of the disease was always very abrupt, and that's one of the things that we learned from this outbreak, is that the onset can sometimes be quite gradual, with nausea, vomiting, diarrhea, and the diarrhea can be quite profound, with the loss of several liters of fluid every day. Headache, dizziness, chest pain, cough, bleeding, and the bleeding, it's called the hemorrhagic fever, but the bleeding is usually more in the form of small nosebleeds or bruising into the skin, so-called petechiae. And people do certainly have extensive bleeding from the GI tract, but that's the minority of patients, and that was certainly Kate and my experience, as well as that we certainly did see some of these people, but the vast majority of people, even those who did die, did not die from an exsanguinating gastrointestinal hemorrhage. And then again, because of the blood vessels relaxing, fluid leaks out of those blood vessels, and so the fluid accumulates in the abdominal cavity, in the lungs, outside the lung tissue, and also in the peripheries, the extremities, etc., so-called third spacing. And that's again something that we see quite commonly now. So again, the specifics, the symptoms are non-specific for the first week or so, and then the hemorrhage happens, and then what we see is that usually by the second week, people are going to declare themselves one way or the other. And sometimes it can be quite abrupt, that they're fine, and then they just sort of go into this precipitous decline. That's going to happen usually in the second week of illness, such that they go into shock, they bleed, their organs start to fail, multiple organs, so the liver and the kidneys and the adrenal glands all start to go south at the same time, or they start to turn around. Usually, once they've stabilized, then the recovery actually is quite rapid for most of the people that we've seen. Although, again, there's a spectrum, and certainly we see people who have quite a bit of body aches and weakness that can sometimes last for several weeks or even months after they get over their illness. So, again, these patients, profound loss of weight, profoundly weak. This gentleman is vomiting, and that's the kind of vomit that you see. It's maybe blood tinged, but it's not usually the bright red or black vomit that you would see with some of the other hemorrhagic fever diseases. The eyes, there's kind of bleeding into the whites of the eye. Again, it's not specific for Ebola. You'll see it with any of the other hemorrhagic fever viruses like Lassa fever or Korean hemorrhagic fever. We also notice that these people tend to get this kind of a premorbid, if you will, stare, where their eyes are open, they're kind of staring, but they're definitely not there. And that was something that was usually very scary, and we would see that sometimes in the day or so before they would die. Bleeding into the gums. This gentleman was sitting up, but most of the people who have this much bleeding are probably going to be sick enough that they're not going to be able to stand up. And then bleeding, and I won't show that for too long, but bleeding primarily, again, is nosebleeds or bleeding into the skin, etc. So again, when someone comes in with those kind of illnesses, it's important to differentiate Ebola from some of the other more common diseases that we see there, especially malaria, dysentery, typhoid fever. There certainly are other hemorrhagic fever viruses in that part of the world, especially Lassa fever. So to this point still, the gold standard way of making the diagnosis is by a test called polymerase chain reaction, or PCR. PCR is it's labor intensive, it requires very exacting methodologies, etc. And one of the big problems that we've had is coming up with a more rapid test. And there are a few that have come out that I'll mention in a little while. But the polymerase chain reaction test is the one that we use, and it's the one that is still the most sensitive. Importantly, especially given all the hysteria about these people who have come back to this country who may have turned out having Ebola, is that the level of virus that you have to have for a positive test is fairly low. And it's a fairly sensitive test, but people can be sick for 2 or 3 or 4 days before the level of the virus is even significant enough that we can detect it. If you can't detect it in the blood, then you can't detect it in the saliva or any other bodily fluids. And so these people in the early stages of illness are not contagious, and that's a very important point. There was just so much made of this person who got on a subway and went bowling and felt a little sick. He was never contagious to anybody else, and that's a very, very important point. The antibody test that we also use, again, don't become positive for several days into the illness, and so not nearly as useful in making a rapid diagnosis of this disease. So there are a couple of rapid diagnostic tests. The Rebov antigen rapid test actually has been approved by the FDA. And what's nice about it is that it's quick. It doesn't require electricity, which is a big advantage, and it's relatively good. But 92% sensitive means you're going to miss 8% of patients, and the negative predictive value also is not great. So it's a step forward. This other one, the matrix test that came out from folks at MIT, actually is pretty exciting as well. But it, again, has not been approved by the FDA yet. Neither of these tests is in wide distribution. Again, the cost of getting them out there, et cetera, still is prohibitive. So there are a few other tests out there as well, but the polymerase chain reaction continues to be the gold standard that we still use to make the diagnosis. So just a few words about the transmission of Ebola, and an awful lot of this came out of the study of what used to be one of the largest outbreaks of Ebola in Kikwit in 1995. In that situation, again, there was 317 cases, and the Centers for Disease Control went out and they did a very, very exhaustive epidemiologic investigation of this outbreak. And the important point here is this issue of person-to-person transmission. So they looked at 173 household contacts of 27 people who had Ebola. And only 23 of those 173 actually developed illness themselves. So person-to-person transmission from the person in the house to somebody else in that house. And all those who got involved were people who had been rendering direct physical contact, caring for the person. So even sleeping in the bed next to somebody with Ebola did not transmit disease. And this is a very important study because, again, it speaks to the contagiousness of this disease, that all the evidence that we have to this point is that it's not that easy to contract. And certainly healthcare workers have gotten infected as a result of the kinds of interactions that we do, especially needles, et cetera. Needle sticks, are certainly very important. But the casual transmission of this virus is really quite difficult. And the transmission within the rural settings is happening really primarily on the basis of bad burial practices, and we'll talk more about that in just a moment as well. There has been not Ebola in this country, but Marburg in 2008. This was a woman who came back from a trip to Uganda, and she had fever, rash, headache, abdominal pain, etc. She was seen twice as an outpatient before she was finally admitted to the hospital, and she came into the hospital with severe hepatitis. The AST is a liver enzyme. The upper limit of normal is about 50, so her AST was 20 times normal or so. She was in renal failure. Her white count was low. She was bleeding. She was confused. she had gallbladder disease as well. So they actually took out her gallbladder. So they had to put her to sleep, opened her up and did all that. They worried about viral hemorrhagic fever, but the tests that they used during this outbreak were non-specific and did not come back positive. So all they did was they took care of her using transmission-based isolation guidelines. In other words, avoidance of blood and body fluids, wearing gloves and gowns, etc. And she got better. She was discharged home after 11 days, and it took a while, but a year later she was completely recovered. So, but a year later, someone from the Netherlands died and was diagnosed as having Marburg. And this person from the Netherlands had gone into the same cave, and so this patient in Colorado went back to her doctors and said, maybe I did have Marburg. And so they had stored specimens that they went to the CDC, and the CDC then did some additional testing, and lo and behold, she actually did have Marburg the whole time. So they went back then and looked at all the healthcare workers who had been involved in caring for this person, and no one became infected. So again, this speaks to the whole issue of transmissibility, is that if you know what you're doing, if you know how to take care of yourself as a healthcare worker, the risk of getting infected is quite minimal. And we can talk a little later about the Dallas nurses and what did or did not happen there, which again continues to be a bit of a mystery for all of us. So how do we treat patients with Ebola? This article came out in the New England Journal of Medicine. It was written by a lot of the people who were in Africa with us, were there right before we came over, especially Rob Fowler. Again, they noticed that the predominant clinical syndrome is a severe gastrointestinal illness with vomiting and diarrhea, and a variety of metabolic issues that happen as a result of electrolyte abnormalities. And so replacing fluids, giving electrolytes back to the patient actually is extremely important and results in a significant improvement. And that was our observation in Kenema as well. So we were as aggressive as we possibly could be, putting IVs in people, starting resuscitation with whatever we had, either lactated ringers or normal saline, controlling their fever, giving them something to keep them calm, antibiotics because of the intense inflammation in the gut, and the bacteria in the gut sometimes could cross over and get into the bloodstream and cause a secondary bacterial infection. And the mortality rate in our hands was about 40 or 50%, that's all comers. A lot of people that came to us were already extremely ill, and actually sometimes they came out of the ambulance already dead, unfortunately. So we felt pretty good about having a mortality rate that's only in the 40% range compared to the historical rates of lethality, which were in the 70 or 80% range. And again, that's been the experience both at Emory as well as at the University of Nebraska in Omaha, is that aggressive intensive care unit type management has worked very well as close attention to giving fluids and electrolytes, etc. So there's an awful lot to be said. And remember also that Marburg outbreak that I mentioned, the 23% mortality rate, that was, again, with similar kinds of management. And so we think that if patients can be caught early, given very aggressive medical care, that the mortality rate can be quite low. But there are definitely novel treatments as well, and there's an awful lot out there that's happening right now. Not a whole lot has been published yet, but giving either whole blood transfusions or plasma from people who have recovered from Ebola is certainly something that's being done. It's being done in a couple different locations in Africa right now, and it's based on the Kikwik outbreak again, as well as a few other outbreaks. But again, very small numbers, and there's actually reason to be concerned that it may not work and may actually make things worse. So the only way to know is to study it and see. There's also, you probably heard of ZMapp, which is a monoclonal antibody, so antibodies that are designed to latch on to the Ebola virus and neutralize it, prevent it from entering the cells and causing disease. And this is a product that's actually made by infecting tobacco plants. And tobacco plants, as they grow, are making these antibodies, and then they're purified and mixed together. So it's a laborious process, but actually looks very promising, and there's studies going on there. Tecmara makes a molecule that interferes with RNA, and so it stops the Ebola virus from making proteins that it needs for survival. And again, that looks very promising. There's a few antiviral compounds. This drug, brincidofovir, actually none of us really thought that the drug looked all that promising, and so I was not surprised that the trial was halted on the basis of very poor animal data. But then favipiravir, there's been a lot of excitement about that drug. It's a drug that's been extensively studied in Japan as a drug that was first designed for treatment of influenza. Again, this trial that was just reported this week in abstract form anyway, was that if people came in with a high viral load, the drug did not seem to work at all. But if they came in with a fairly low or moderate viral load, and were given the drug right away, that the mortality rate was cut from 30% to 15%. And again, the 30% was historical controls, 15%, but again, it was only in about 46 patients. And so it's promising. It certainly deserves an awful lot more attention. But again, it's premature to make any but very tentative conclusions looking at a drug that's only been studied in fewer than 50 patients. One of the also big and exciting areas is development of vaccines, and there's several different vaccine platforms that have been investigated, only two of which are progressing into very large-scale trials. The first is this adenovirus, and you've heard about it being a chimpanzee adenovirus. The issue is that adenoviruses are common cold viruses, and there's hundreds of them, and if you're exposed to one of these common cold viruses and you recover, then you make antibodies against it. So if you get a vaccine that's based on this adenovirus, then the vaccine's not going to work because you make antibodies against it right away. So the chimpanzee adenovirus is one that came out of Africa and that none of us have ever seen. This is a pretty exciting platform. Vesicular stomatitis virus is a virus that causes mouth ulcers in ruminants in South America, but it's also a very exciting platform. And Dr. Heinz Feldman, who is the chief scientist at Rocky Mountain Labs in Hamilton, actually developed this vaccine. Both of these vaccines are similar in that what they've done is they've cloned in the gene that makes the glycoprotein, the outside coat of the Ebola virus. And these viruses then are live. They're given to people, and the adenovirus replicates only one cycle. The VSV actually replicates several times. And in its growing, then, it makes a lot of this glycoprotein. You make antibodies against it, and the antibodies then cross-protect against the Ebola virus itself. There's huge excitement, especially for the VSV, and there are two large trials that are ongoing right now. One's going on in Monrovia in Liberia, and it's a placebo-controlled trial where 1/3 of the people get placebo, 1/3 get the chimp adeno, 1/3 get the VSV vaccine, and 9,000 people in each of the three arms are being offered this vaccine. And that trial started about 3 weeks ago. And again, we don't have any data yet, but it's very promising. The second trial is going on in Sierra Leone, offered to healthcare workers only, looking at the VSV alone in an open label trial. And that trial is actually going to start day after tomorrow. And the goal is to offer the vaccine to 6,000 healthcare workers and frontline people and determine how well the vaccine works in that situation. It sounds like it's been a long time coming, but actually to develop a vaccine into a phase 3 trial within a year of an outbreak actually is lightning speed. You know, when you're given all the logistics that it takes to mass produce a vaccine that's pure and clean and can be given in such large volumes to so many people. Actually, it's really quite stunning. It takes usually 5 or 10 years for a vaccine to even go through phase 3 trials. So doing it this fast is really quite remarkable. So let's talk about this current outbreak and then how Kate and I got involved. It started actually in 2013, and this is a map of Guinea. What you'll notice about Guinea is that it sort of surrounds Sierra Leone and Liberia, and there's this little peninsula that's right at the head of the Mono River, which comes down here. And so the outbreak started in Gekadu, and it was a small village. There was a 2-year-old boy who actually ended up, he was playing around a bat roost. This dead hollow tree had a lot of bats roosting in it. And this little boy actually caught and was playing with a bat. He got ill, died, but gave the virus to his sister, his grandmother, and his mother. All of them became ill, and they all died. And as is the case, in these villages, people came from all over to help in the burial process and the mourning process. And the borders of all these countries are really quite porous, such that people came from Liberia and came from Sierra Leone because the villages had people from several different families that may happen to be in different countries. So these people came over, helped prepare the bodies for burial, and in the process got sick, but didn't get sick until they went back to their own villages, and then got sick and were taken care of by their own people. And so it began this cascade, which spilled over into Sierra Leone quite quickly as well, going down the Mono River, but then also went all the way over to Conakry, which is the capital. And this is happening in a situation where you couldn't pick a better place for an outbreak to happen because of all the civil war, the strife, the internal conflict, the porous borders that I mentioned. A lot of people are very mobile, going around looking for jobs, itinerant farm workers, etc. A very, very inefficient healthcare system over there. Again, we're just starting to recover from decades of civil strife and war, etc. Different from Uganda, which has seen lots of outbreaks now of Ebola. Nobody had ever seen Ebola in that part of the continent before. So nobody really knew much about it, didn't know how to protect themselves, etc. And unfortunately, what's still happening in Guinea is a high level of resistance to the outbreak. People still don't believe in Guinea, that it's real. They think it's a myth. There continue to be attacks on the Red Cross outposts in Guinea. And that continues to be a huge impediment to this disease coming under control. So as I mentioned, cases started in Conakry, which is a big place. Kate and I were evacuated through Conakry, and the 2 million people, I don't think hardly any of them had electricity or running water in their houses, and it was really quite the slum area. So it spilled over into other parts of Guinea, and then into Sierra Leone, and then into Liberia. And one person actually got sick and tried to fly out, and so he actually got sick in Lagos, which has 21 million people population. And fortunately, they were able to get on top of that, and there were only about 20 cases in Nigeria, because if that had spilled over into the 21 million population in Lagos, it would have been just an entire game changer for us. So Nigeria has been Ebola-free now for a couple of months. So the numbers continue to rise. As of this week now, a little over 23,000 cases. And again, I've got a big caveat there because these are cases that are just documented. And so we think that there's probably at least another add 15 or 20%, perhaps even more to that number. Again, the 3 main countries continue to be Guinea, Sierra Leone, and Liberia. And right now, Sierra Leone is the area that we're having the greatest amount of difficulty bringing under control. So again, and this happened to us. We had 2 strikes while we were there because the people hadn't been paid. And so there were a couple days when Kate and I went in with the other 3 people that we were there with, and we were the only people caring for 90 people with Ebola. Unpaid healthcare workers, inefficient training and infection control, lack of personal protective equipment was a big problem, and the big challenge for us was trying to figure out where we were going to get our gloves and our gowns for the next couple of days. So these are all big problems, as well as any typical outbreak issue with logistics, supplies, etc. And I mentioned burial customs, and again, the habit, and this is something that's gone on for millennia in this part of the world, is that when someone dies, you believe that you need to interact with that deceased person, otherwise they're going to come after you in the afterlife. And so you bathe the body, you clean the body. In some villages, you actually spend the night in the hut with the deceased person, it's very difficult to get people to change those habits because these are very, very ingrained cultural norms. One of the things that's helped bring the infection under control in certain places is, again, the acceptance of safe burial practices. In places where it's not happening, the outbreak either went away and is coming back, or never really went away at all. So what's a small-town infectious disease physician from Missoula, Montana doing over there in Africa anyway? So this is St. Pat's Hospital, and I've been here for 25 years. Rocky Mountain Labs in Hamilton in 2007 decided to build a biosafety level 4 research facility there. Biosafety level 4 means it's the maximum containment facility that's possible, and they study a variety of infectious diseases to include Ebola. Kate Hurley and I and several others designed a training program to prepare healthcare workers to take care of people who might be infected at Rocky Mountain Labs. And that's never happened. The lab's been open since 2008. We've never had a single person get an exposure that's required them to come to the hospital. But we are trying to be prepared, and so we have this what I thought was a fairly elaborate, fairly comprehensive training program, but it had never been field tested, because again we'd never had an exposure, so we didn't really know how good it was. So when I heard about this outbreak and it looked like it wasn't going to go away, I decided that I just really had to go and see for myself what was going on, to learn more about this disease, and then to see how we could improve the training program that we have here at our hospital. So I contacted the World Health Organization, and then I contacted a few close friends. I called Kate, and then I called Dr. Nahid Badilia. She's my counterpart at Boston University at their level 4 laboratory. And I said, hey, let's go to Africa. And Kate said, huh, sounds like fun. That's not exactly what she said, but she said, sounds very interesting. She was certainly willing, and the hospital was very supportive of our going. They gave us a lot of supplies that were, again, very appreciated. So we went over there with just a couple of big duffel bags full of gear that was donated from the hospital. And if you've never been to this part of the world, again, these are beautiful countries, and I'm really excited about going back to Sierra Leone after this outbreak is over, because they have beautiful beaches, lush tropical environment, friendly, wonderful people. We were so welcome there, and we never felt more comfortable than we did in these villages. It was just really a remarkable experience. The other thing that I was really struck by was how much weight these people are carrying on their heads. And notice this woman doesn't have her hand up here like I would. They were just walking around up and down hills, barefoot, with these enormous weights on their heads. So that I thought was very impressive. So I decided to try it. So here we are, moving into our office in Africa. And this was our command center, and it truly was an international effort. This gentleman was from Germany, this gentleman was from Italy, this woman was from Zambia, and David Peremka was from Ohio, which is sort of like a foreign country, if you ask some people. And we had other people from all over the world also. It was truly, that was one of the most interesting parts of it, was just interacting with people from Brazil and Japan and almost you name it, Australia. We had a few run-ins with some of the Aussies as well, which that's a different story for a different time. Yeah, I made a lot of money on this. Actually, we were paid $1 by WHO for going over there. But I was just struck by the fact that $1 is the equivalent of 4,375 Sierra Leoneans. So there I am with about 10 bucks. I sent my wife this picture, and she said, "Oh, are you starting a drug cartel over there?" And I said, so we met up with some other people. This is Ian Crozier, who is an infectious disease physician who trained at Vanderbilt and was stationed in Uganda doing HIV work, and David Paremka, a critical care doctor from Ohio. And then over there on the side is Lena Moses, and she's an epidemiologist from Tulane University. And again, so Ian and David and Nahid and myself and Kate, we were the 5 Westerners who were clinicians. And we were over there with a few very, very good nurses, and then a variety of people who were doing their best, but really were not very well trained. And we went to the Kenema Government Hospital. Now, Kenema is a town of 600,000 people with 75% unemployment. And at the time we were there was no other hospital in the entire country of Sierra Leone that was accepting Ebola patients. So our census was about 90 patients on a daily basis. And the ambulances would roll in any time of day and would, their ambulances in name only, they actually were providing no care. They were just kind of transporting people, and sometimes there were 5, 6 people in those ambulances, and they would arrive at any time of day or night and just sort of deliver those patients to us. You can see all the plastic everywhere. This was initially the Lassa Fever Hospital that was retrofitted to be the first Ebola treatment unit. And the view out of our office, again, was sheets and sheets of plastic everywhere where people were trying to sort of be pushed into one direction or the other. Notice that the sidewalks are all elevated because in the rainy season, which is when we were there, sometimes the rain would fall for 2 hours straight and you couldn't hear yourself talk because the rain was coming down so hard. So being on an elevated platform allowed you at least keep your feet dry. Again, just more of the same here. You can see this is where the ambulances would come in. That was the triage area, the holding area, where people who were suspect, were not confirmed yet, were waiting for their blood test results to come back. So we donned our personal protective equipment in this little makeshift shed. And you can see there's a little mirror over here where you would take a look and make sure that all of your gear was appropriately positioned, and then you would have your partner look at you and make sure you didn't have any holes or any breaks, and make sure your mask and face shield and everything else were appropriately situated. Murdoch's has not contacted me yet, despite the fact that I've really sung their praises, because I got these irrigation boots at Murdoch's. And I was the most popular guy in Kenema with these boots because everybody wanted my boots. They were high quality, $50. And I did leave them behind, but I had several people become my new best friend because they really liked my boots a lot. Otherwise, you know, it was whatever you could scrounge up from around there. And this is what we looked like when we were dressed up. So we would write our names on the front of our aprons, you can imagine it'd be a little scary for an African villager to see people like us descending upon them. Not to mention the language barriers. They all spoke English, but sometimes their English was very heavily accented, or they might speak a local dialect, and sometimes they spoke Mendi, other languages as well. So we had the benefit of some locals who were able to translate for us sometimes. But then, even if they spoke English, trying to understand us speaking through these N95 masks was sometimes quite difficult as well. And so you really had to focus on articulation, speaking very slowly and directly, and making sure you made eye contact with these people. Because sometimes, I think the best way of explaining yourself sometimes is with hand gestures and with eye contact. And we got quite proficient at that. And it was exciting for a while. You know, we were there for 3 weeks, and after the first week or so, what you'll notice here is nobody's smiling anymore. So Kate is like, oh, do I have to go back in again? Nahid the same way, you know, it got to be a real grind because we would it was so hot, and you put on this gear, you know, I mean, it's equatorial Africa, so 85, 90 degrees, 95% humidity, rainy season. You put on this suit and you go in and you can spend 2, maybe 3.5 hours at the most. And then you came out rehydrated, dried out, and then put your suit back on and went back in again. And we went in twice at least, usually 3 times a day. And we were there with no days off because there was nobody else to take care of patients for us. And so it got to be a real grind, and we were quite exhausted by the end of our deployment. This is Tom Frieden, who's the director of the Centers for Disease Control, and he was kind enough to come pay us a visit about halfway through our visit. And I was reminded of him when there were so many controversies that happened over here. But it really was kind of like Groundhog Day. Every day was kind of the same. You'd go in, you put on your suit, you go and see how many dead people there were, count the bodies, radio out about so-and-so has died, and then you go in, you do all that you can. But every day there was some new crisis that also happened, whether it was the head nurse who contracted Ebola from a baby that she didn't think was infected and was changing the baby's diaper and got infected that way and ended up dying. It just seemed like there was always something new, some new crisis to contend with that sort of ended up taking up a huge amount of energy and emotional energy as well as physical. But the good parts of this were the children and the survivors in general. And this is, again, is Dr. Ian Crozier. Kate's over there on the side, and then I'm in the back there. And these kids, unfortunately, all were orphaned. One of the big dilemmas right now is what are we going to do with all these orphaned children? But there's 3 boys in the middle there that were all brothers, and the oldest of the 3 was taking care of his younger brothers. Dr. Ian was just, he was like a second father to all these kids as well. Really wonderful man. What also was really gratifying was seeing these survivors helping each other. So Margaret, in particular, she came in with her husband, Eddie. Margaret was never very sick with Ebola, but she certainly was positive. Eddie ended up dying. They came all the way from Freetown, which is the capital, so 6 hours drive away, left her 6 children behind. And then when Eddie died, I asked Margaret if she wouldn't mind helping care for some of these orphans. And the next thing I know, she's taking about 6 of them under her wing and is changing their diapers and feeding them and making sure they actually got good care. And an awful lot of these kids, I think, survived because of what Margaret did. Similarly, Isaac, he had a brother also whose name was Isaac. The brother Isaac was married, and his wife and his mother and Isaac, number 2, all came down with Ebola. And the other Isaac was a nurse. And so he came in and helped take care of all of our patients, including his family. His mother died, but Isaac too, and his wife both survived. Unfortunately, the Isaac nurse did get sick, got a fever. We were really concerned about that, but it ended up he just had malaria. So we treated him for malaria, and the next day he was back in the wards taking care of patients again. So quite remarkable, you know, and those kinds of selfless acts, I think, were, again, some of the most remarkable things that we saw. We had so many people that we had to open a second ward, a recovery ward. So the cholera ward was sort of down the hill, and it held 25 patients. The people who we were pretty confident were going to survive because they made it through their second week or so and were up and eating and weren't having any fever anymore, their diarrhea was gone, etc. They would go down there, and then they would wait until their blood test came back negative. And so what we would sort of set up a little Academy Awards where we would have everybody sitting in their little plastic chairs. And we would come down with a sheet of paper and very ceremoniously say, okay, Isaac Conti, come on down. You are cured and you can go home. And so these are all people who have beaten Ebola and are ready to be discharged. When they're discharged, everything that you brought with you is burned, including your clothes. You're given a fresh set of clothes. You take a shower in dilute chlorine water. and are discharged to go back to your village and given a certificate saying that you are cured of Ebola, which hopefully will help reintroduce you into the community, because there's an awful lot of scariness and distrust, etc., of people who go off to the wards. But these people all survived, and you can see just how happy they are. There were a lot of dancing and laughing going on in that part of the ward. Again, the smiles. I didn't know what Pop Rocks were, but the CDC, some of the folks from CDC brought a bunch of stuff over, and this is Ian giving Pop Rocks to these kids for the first time. And that was just, again, really kind of fun. Look at this smile. This woman is one happy lady. I mentioned some of the good nurses, and this is French. And he became the head nurse. Again, we were there for a few weeks, and these people had been there for months already, and we left them behind. So just I have enormous amount of respect for how much courage it took just to get up and go to work every day, day after day after day. And this young boy, again, is one of the survivors that we knew was clear, so we could actually embrace him for the first time. And these, again, are others who we knew were going to survive. And again, so this is Kate and Ian and myself and Dave Peremka. We were able to talk to them across the first time I went up there, and I was talking to these people. They didn't know who I was. You know, I said, well, it's Dr. George. Oh, Dr. George, because they had never seen me without my gear and my face mask and everything else. Oh, that's what you look like. So that was good to actually put a face to a voice. So we finally were going to leave, and the day after we arrived, Air France stopped flying into Freetown, and so there was no way in or out. And so WHO contracted a United Nations plane to medevac us, and we had to make our way back to Freetown. So we had to go through 12 checkpoints, and each of these checkpoints was armed with these young boys, and 4 of them we actually had to get out of the car and have our temperatures taken. And I have no idea what would have happened to me if I had a fever, but thank goodness I didn't. So we made it back to the airport, and there we are, all looking a little the worse for the wear, but certainly glad to have made it. Every day, at the end of the day, we would say, okay, another day with no breaks in technique, another day with no needle sticks, no exposures, and it's like, phew, okay, let's go back and relax. So things are better over there, certainly better than when we were there, but there's an awful lot of obstacles still before we get to zero. Again, the progress is somewhat precarious, especially now in Guinea and Sierra Leone. Numbers have stabilized or sort of creeping back up. Shifting epidemiology such that there's little outbreaks in new parts of these countries where they've not yet gotten organized. They don't have an Ebola treatment center set up in that part of the country, don't have the staffing, etc. An awful lot of undetected transmission probably is happening. Dangerous burials continue to happen. Money, the United Nations has estimated that they need about $1.5 billion for the first 6 months of 2015, and right now they have about $600 million in the bank, and so they're way short. And a lot of pledges have happened that have not yet come through. And of course, the rain. We're getting back into the rainy season, and that's a huge problem. So I mentioned the precarious progress. You can see, again, the color coding here, but the numbers went way up and then went down, but they've sort of stabilized, and now still in Sierra Leone, we're seeing about 60 or 80 new patients per week still coming out. Guinea is starting to tick back up again. Liberia really is the true success story, and as bad as things were in Monrovia in October and November of last year, they really seem to have come under control significantly. This is worrisome because this is the crosshatches are the people who are infected who were not on some kind of a contact list. So every time somebody's identified, then the CDC and other people go out and they identify all the contacts of that individual and they monitor them for 21 days to see. And then when somebody comes in with Ebola, then they were able to cross-check and see if they were people that they were identified or not before. And you can see that the vast majority of these people, especially in Sierra Leone, are people that had not been on any kind of a contact list at all. And so that speaks to a lot of undetected transmission that's still happening. Dangerous funerals, again, I mentioned the fact that these people just don't want to change these habits, and as soon as the situation seems to improve a little bit, things start spinning out of control again. So again, in Sierra Leone and Guinea, you're seeing an awful lot of unsafe burials being reported, and again, those are the real drivers of the outbreak in terms of the public transmission. And this is a fairly typical road, and the rainy season over there, I mentioned, you know, it'll just rain just so hard for hours at a time, but you can't hear yourself think, and this is what happens, is that even these Land Rovers are having trouble getting through. I think that's my last slide. Yes. So you guys, I really appreciate your attentiveness, and I'm glad to answer any questions or whatever. I don't know if I've gone over the allotted time or not. I apologize if I did. Thanks for your attention. Yeah.
What's the situation like right now? Did you leave it in care of somebody else, or did somebody else come in and leave it?
Yeah. So we were there, and WHO, they had other people who cycled through, and they didn't want anybody to be there for more than 3 weeks at a time, again, because of just the intensity of what we were doing. So when we left, a new crew came in, and that's the way it's gone. Plus, there's a lot of other organizations that are obviously being involved. MSF is one of the leaders, also Partners in Care. There's 4 or 5 different organizations in addition to WHO.
Do you think all the protective gear is necessary since that lady in Colorado didn't infect anyone even though they weren't using nearly as much security measures?
Yeah, that's a really good question. Did everybody hear that question? How much gear is really necessary, you know? And I guess the best way to answer that is that you could study Ebola in the laboratory on a bench top, you know, if you really were careful and didn't make any mistakes. So the gear is designed to give you extra layers of protection in the event that you make a mistake more than anything. One of the things that Dr. Frieden was dinged about was that he said that any hospital is prepared to take care of somebody with Ebola, and that a mask and a face shield and a surgical gown and a pair of gloves really was sufficient. And he was correct. But then, when the 2 nurses in Dallas became infected, then he was really heavily criticized, and an awful lot of additional recommendations came out on the basis of that. We still really don't know exactly what happened with these nurses, with the exception that this was very early in the outbreak. They really hadn't, had a whole lot of really good training, and the most dangerous part of the entire process is the doffing of your gear, of taking off your gear. If you don't do it correctly and you don't decontaminate your hands in between each step, these nurses were describing going in and out of their PPE as many as 20 times during an 8-hour shift, which was far and away. I mean, we know an awful lot more about what not to do now. And so somewhere in that process of hurrying in and out of their gear, they got exposed. So I'm not sure that's a good answer to your question, but the more training you have, the better off you are. I think all of us now still recommend the use of the kind of gear that we're talking about.
I have 2 questions for you. One is close to home and one's further away. Initially, there was a report that St. Pat's was one of 4 hospitals in the country that was prepared to deal with Ebola patients who might have Ebola. And then that was rescinded later on. What was going on there? Why was that? The second question has to do with President Obama's decision to withdraw most of the military from Liberia. Do you think that was appropriate? Maybe why didn't we send them to Sierra Leone?
So the second question is probably easier to answer than the first. The division of labor, if you will, in the three countries follows the old colonialism, such that the United States basically took care of Liberia, the United Kingdom took care of Sierra Leone, and France takes care of Guinea in terms of the massive amount of resources. You know, the initial military response was to go and build 17 Ebola treatment. And as the outbreak came under control, they realized they didn't even need that many. And so their mission ended. And the people who were there actually were not frontline healthcare workers. They were construction workers. They were military, but they were involved in the development of the airfields and the treatment units and the water system, et cetera. And I think mostly there's adequate numbers of those kinds of facilities now in most of the places. So their mission sort of became redundant. Oh, yeah.
First of all, an outstanding, dense, and informative.
Oh, I was afraid I packed too much. You can talk for hours on this.
I have a couple of questions. One is a biologist, zoologist. I'm looking at the bat at the moment. Are they being persecuted, eradicated, surveyed? Do we really know what goes on in the biology of the bat regarding this disease?
So, great question. You know, there's over 1,000 different species of bats, you know, and they're fascinating animals. You know, people are kind of put off by them because of fear of rabies and whatever. But you know, if you go back into the fossil record, I mean, bats have not changed in millions of years. They're like sharks. They're just perfectly adapted to their environment. And an animal like that also has evolved its own virology. You know, and so these viruses probably have been indigenous to bats for time uncounted. Really, it's the migratory patterns and habitat destruction, et cetera, that force bats to come more into contact with either humans or other intermediate species of animals. I don't know enough about bat ecology to tell you, but my understanding is that first of all, there's only 3 or 4 different species of giant fruit bat that are capable of reproducing this virus. So not all bat species are equally susceptible to the virus. And the 3 different species of fruit bat that are capable don't appear to get sick. Perhaps shed virus intermittently, especially pregnant bats, it's probably in their birth products, et cetera, and they probably shed more during the process of parturition.
Follow
yeah.
And my kind of pivots off in your answers is that it would seem to me that bats have been around for tens of millions of years, so have these, and humans, of course, have been there for many hundreds of thousands of years with many of these same cultural procedures. Might this Ebola or something equivalent have raised its head a number of times previously?
Oh, I think that's, yeah.
Not really been recognized as we are able to give it a label now, and the way we transfer information, that this is most likely a fairly, I don't want to use the word common, but certainly not a historical moment regarding this phenomenon.
Again, a good question. You know, the first outbreak that was recognized was in 1976, but I think it's quite likely, almost certain, that this was going on, you know, for a long time before it was finally recognized. Again, happening primarily in these small isolated villages. We learned about the one in Yambuku because there was a Belgian missionary mission hospital that was there, and it was only because the mission hospital was there that they got the word out that this outbreak happened. And then, of course, the outbreak really happened because the nurses there, they had a total of 3 syringes and 3 needles that they were using for hundreds of people, and so hundreds of people would get injections with the same 3 syringes every day. So it's that kind of amplification that would not have happened before modern, if you will, methods of transmission, or methods of you know what I'm saying, losing my train of thought. So I think small outbreaks probably happened and probably died out, you know, and then the larger outbreaks are happening as a result of people coming into the hospital and getting those kinds of intense interactions that include very often the reuse of things that shouldn't be reused.
Let's take 2 more questions, and then you can come and talk to Dr. Risi individually.
Has there been a faster international response to this kind of an outbreak? Could it have been contained?
Absolutely. Yeah, there's been an awful lot of retrospective analysis of why this outbreak got so bad. And a lot of it has to do with the fact that every nation that's supposed to be contributing to the WHO has cut back their funding. So WHO has been living on a shoestring budget for a long time, and that they had to pare back an awful lot of their investigations and epidemiology, et cetera. There is now, and hopefully that's going to continue, much more robust combination of international organizations such that hopefully this will never happen again. But yes, you're absolutely right. It could have been stemmed quickly had we had the resources.
Just from your own experiences, what are ways that recruitment towards more healthcare workers, anything like that, to get more healthcare workers in the areas that are being affected?
So how do we get more healthcare workers to go out there? And yeah, well, you pay them $1. You know, I mean, I went there for the big bucks. No, you know, I think there's a lot of altruistic people out there who are just looking for an opportunity to learn and to give back. And there's organizations like Partners in Health, like International Medical Corps, like the Peace Corps, there's lots of different ways to volunteer to go. But I wouldn't go unless you were well trained. But what they needed more than anything else was nurses. And Kate actually was the first international nurse to be in Kenema, actually to be in the entire country as far as I could tell. And what we recognized right away was we didn't need doctors, we needed good ICU level trained nurses, because that was what really made the difference. And I hadn't put an IV in since 1983. So I was a little nervous there, you know, with a dehydrated, dark-skinned person who had Ebola, and there I was with a needle in my hand. So Kate just sort of held my hand through it and walked me through it, and it all came back to me, kind of like riding a bike.
You can work in any ICU in the United States now.
That's right. That's right. So yeah, I'll stick around if anybody wants to ask me additional questions. Thanks for your attention.